Good afternoon, everybody, and welcome to this education session on chemotherapy and immunotherapy updates and colorectal cancer. I'm delighted that you're able to join us. My name is Claire Coughlin. I'm the clinical lead for Bowel Cancer UK, and I'll be chairing this afternoon's session. We've got an absolutely fantastic speaker, and I'm so delighted that he's been able to join us this afternoon. Professor Mark Saunders is a consultant clinical oncologist at the Christie NHS Foundation Trust. He will provide a brief history of the evolution of chemotherapy over the last 25 years and concentrate on the management of patients with chemotherapy, including genetic mutation targeted therapies and immunotherapy. So Professor Saunders received his medical degree from Charing Cross Hospital, it says here in front of me. He spent 5 years working in general medicine before specialising in oncology. His main area of interest is running all phases of chemotherapy and radiotherapy clinical trials, including novel agents with associated response, toxicity, biomarkers and radiology. He's written a series of protocols for clinical trials that have been funded, completed and published. Mark also is a member of a number of trial management groups, data monitoring committees, and he's a member of numerous NCRN and Cancer Research UK committees, and previously chaired the Northern Cancer Drug Fund Committee. On top of all of that, he is absolutely fantastic to us here at Bowel Cancer UK, works tirelessly with us as part of our medical advisory board, really helps me every single year by teaching on the MSc module, and I'm absolutely delighted and very grateful that you're here with us this afternoon, Mark. So over to you.
Well, thank you, Claire, and thank you for everybody at Bowel Cancer UK for inviting me along. And thank you to everybody who's taken the time to join in. I saw a lot of the names that are appearing at the start, and I recognise some of the names, and they come from, obviously, you come from quite a range of places throughout the UK. Now, I've got a number of slides, and what I hope to do at the end is actually make you a little bit more confident about the exciting times in colorectal cancer. When I started many years ago, there was just 5-FU, that one drug. Now we have lots of drugs, and as you can see from the next slide, just pressing it here. Here we are. The next slide. There are lots of drugs, and this just gives you a summary. And probably a lot of you who are colorectal nurses or involved in colorectal cancer chemotherapy would recognise these names. And the backbone is 5-FU and the oral drug capecitabine, and also we use oxaliplatin and irinotecan. And there are the much more newer targeted therapies, such as the EGFR inhibitors, such as cetuximab or panitumumab, and also the VEGF inhibitors. And we also now know there's a lot of third-line treatment. So say at the start, we just had 5-FU, which was one line. Now we've got drugs such as Lonsurf or regorafenib or frequentinib. And so we've got third line, fourth line, and possibly even fifth line. And we've got a lot of targeted therapies as well. And we've got immune therapies, which I'm going to mention at the end. So really, from going from one drug, there are lots of drugs now. So you can see here all the drugs I just mentioned there. And I think the figure to mention is that right at the top in the red box. And that's if you just give, for somebody with metastatic advanced colorectal cancer, so liver metastasis or lung metastasis, their supportive care gives you about 5 months. I know it varies, and that's a median figure, so some do a lot better than that, but some do a lot worse. But that's the figure. It's awful. When you look at all of the different combinations there, capecitabine, and often they have these funny names like FOLFIRI, which is a combination of irinotecan and 5-FU. And you can recognize all the newer drugs such as encorafenib and nivolumab, ipilimumab at the bottom. But you can see there we've gone from 5 months up to about 3 years. I said this and was quite proud of this once to a patient conference, and this young woman got up and said, well, that's nothing. And I do agree. It's 5 months going to 30 odd months is great. But really, for somebody who is in one of the early onset cancers, so people under 50, going from a few months to only 3 years is still nothing compared to what they really want. They want decades, but it's certainly a lot better than what we were with. So next slide. And you can see here, if you look at, can you see my mouse? Is my mouse working on here? Yeah. Can anybody see, Claire?
I don't think I can see it. Move it. Can you just put it on the white?
I'm moving on it. You
Yeah,
can't
no,
see it.
I can't see
No,
it.
okay, doesn't matter. So if you go from the black dotted line on the far left, it's a survival curve with just with just best supportive care, and as you can see, increasing the drug, so adding capecitabine, adding 5-FU, adding irinotecan and 5-FU, or oxaliplatin and 5-FU, and then the green line with the 33%. Above it, right in the middle, that's adding drugs such as cetuximab. You're moving that survival curve right across. So essentially what you're doing, you're making people live longer with all these new drugs. And you can see in the far right corner of the slide, there's a big arrow going upwards. And here you can see these two lines don't reach the bottom. So those people are cured. That's 10 years. They're cured at that point, and often they're cured with surgery. And so what we often do as you as chemotherapy nurses and us as oncologists is give chemotherapy. We hope to shrink the cancer and to allow lung metastases or liver metastases or peritoneal metastases to be removed. And so we can change the outlook of patients dramatically by not just increasing their survival, but with chemotherapy, we can actually help to cure them as well. So next slide. The next slide as well. Now, this is the first targeted therapy that came through. You would have heard these EGFR inhibitors, and the drugs that we're talking about there are things in the top left there: cetuximab and panitumumab. Now you can see I've drawn a very colourful cell at the top with a little blue box, a white arrow and a red nucleus, and the orange is the cell. And essentially you'll see this in a number of my slides because they all work the same way. You have a receptor at the cell surface. You have the white line, which is a signal transduction pathway, and the red, which is the nucleus. And in this particular case, with epidermal growth factor, it attaches to the blue box. It stimulates this nucleus via that signal transduction pathway with RAS and RAF and MEK and things to double and divide. And so patients with a lot of epidermal growth factor really do badly because their cancer cell will actually grow so much and divide so much. And so we have inhibitors now of this process called cetuximab and panitumumab. If you can, next slide, please. And that's showing it there, and that's the RAS pathway with all the RAS mutations. And if you go on to the next slide, you can see here, if we've got patients that are wild type RAS, so that means they don't have a mutation in that signal transduction pathway. If you add that onto normal chemotherapy, such as irinotecan and 5-FU, with the orange line there is above the blue line. And so what happens there means there is that those patients survive for longer. So that means that adding cetuximab onto that chemotherapy at that time, this is about probably 15 years or so ago, actually made patients do a lot better by adding cetuximab into those patients that had a normal signal transduction pathway, a normal RAS, a wild type RAS. So next slide. And what many of you would have seen is rashes with these drugs. And what's interesting is the more the rash, the more the response. And so you can see there with the big orange boxes in the histogram there, those patients there that have an awful rash tend to respond a lot more. And you can see some of the rashes there on that poor young woman's face there. And it's very difficult sometimes when you give a drug and you say, great, you're going to respond well. But cosmetically, it's very hard, whether you're a man or woman, to go out with lots of spots. But as a lot of you will have seen that have worked with these drugs, the rash tends to settle. Women certainly can use makeup. And men, I always say, start to get a bit redder and blotchier and look like they've been out on the boats all the time. They look more rugged, I think. So people can cope with it. And certainly it can actually increase your survival greatly. So next slide. So we're now going to talk about colon, left and right colon. You think colon cancer is the same, and I did for many years. But the colon, if you look at in the top right-hand box of that nice colourful diagram, it says splenic flexure. The colon is split there. On the right side, which is coming round towards the cecum, that's derived from what's called the midgut. So embryologically, it's very different. on the other side of the splenic flexure, the left side of the colon is derived from the hindgut, and it's really different. And so left-sided colons are about 2/3 and right-sided about 1/3. So there's more people with left-sided colonic cancer, and people with left-sided colonic cancer actually do better. They tend to respond better to drugs. Their outcomes are better. So it's really different now. So we're always looking now, what side is the cancer? Is it left or right side? And then that can help us decide how patients are going to do and what chemotherapy to give. So if you could move to the next slide. And this shows it there. It's derived from the midgut, the right colon, and the hindgut, the left colon. So the next slide. And you can see it's more diagrammatic there. You can see it's all split at the splenic flexure, and the left side is one side and the right side is the other. So next slide. And as I said, right-sided tumors, they're derived from different places, but they're very different microbiome. For example, the bacteria on the right side of the colon is very different to the left side. And you probably, if any of you are involved in clinical trials, we're often collecting samples now of feces to look at different bacteria. So we're looking at the microbiome. The genetics are very different. You have more mutations on the right side than the left. So right-sided colons genetically are different, bacteria are different, and they're derived embryologically from a different place. So they're very different right-sided. So next slide. And this was a study looking at chemotherapy with or without cetuximab or bevacizumab. And I'm not going to go through that particular study, but it was a big study. And you can see there wasn't much difference. The overall survival was just more than 30 months in both arms. But if you go on to the next slide, you can see there, the patients with the left-sided colonic tumor in white have a median survival of 33 months, and with the green one, have a median survival of just under 20 months. So the left-sided tumors in that trial did a lot better. So left-sided colon is better. Next slide. And if you go on to the next one as well, just click it again. Oh, yeah, okay, let's stick on this one. If you look on the bottom two graphs, and it says overall survival, if you look on the left side curve, that's left-sided colorectal cancer. And you can see there, it's very similar to the graph I showed you earlier on. If you add cetuximab, you get an advantage, which is great. If you look at the right side, which is the bottom right-hand curve, you can see both lines overlap, and there really is no advantage of giving cetuximab in right-sided colons. So now, we now know that, yes, let's give cetuximab or panitumumab for left-sided cancers, but we just don't give it for right side, because this and a number of studies show that it really doesn't benefit patients. So it would give you the rash, perhaps, but without much benefit. So if you go for the next slide, so that summarizes it there, really. Again, all the left-sided ones, yeah, let's give epidermal growth factor receptor inhibitors, such as cetuximab and panitumumab. The right-sided ones, no point in giving that one. So do you try another drug? And I've written down bevacizumab there because that's another new drug, and you're probably all going to say, well, we can't give it anyway. But in fact, you may be able to give it soon. The NICE meeting looking at first line and second line bevacizumab is actually tomorrow. And I obviously can't say what's going to happen there, but I'm high hopes that they'll allow us to give it first and second line. And so it may well be that you might find for left-sided tumors, you're giving cetuximab or panitumumab, and right-sided tumors, you're going to give bevacizumab. So if we go on to the next slide, this is bevacizumab. Now, this is a lot of words here. There's no point in you absolutely reading all of this. All I'm going to say is that bevacizumab becomes more beneficial the later you use it. So if you look in lines like first line, second line, third line, bevacizumab in the first line setting, there's 7 studies here, and there really was very little difference whether you added it to chemotherapy or not. So there's not much difference. There is a bit of a difference. That's why people, certainly in Europe and North America, use it, but the benefits are small when you use it first line. If you look at the next slide, there's another complicated slide as well, but you can see there that the two graphs there are called forest plots, and you can see the red squares If they're to the left of the line, so the side that they are, that means that bevacizumab is more beneficial. And so it looks as though second line, actually, yes, bevacizumab is much more beneficial than first line. And for people that give a lot of chemotherapy for colorectal cancer, we know we can already use bevacizumab in a third line setting with Lonsurf. And we know that's, I'm going to show you a slide later that shows there's a big advantage there. So bevacizumab will hopefully become available soon, and it's more beneficial the later lines you use it. So the next slide. So this is where we are at the moment. We've got the FOLFOX and the FOLFIRI, so oxaliplatin and irinotecan drugs. We've got the epidermal growth factor receptor inhibitors, such as cetuximab or panitumumab, and they're really good in the left-sided tumors, as I said. There's FOLFOXIRI, that's a combination of all of them. And even though there's 3 drugs there, it actually, in the right person, is tolerable. I wouldn't say give it to somebody who's 80 and frail, but you've got somebody who's 50, 60, 70, who's fit. Yeah, FOLFOXIRI can be a very active treatment. There's bevacizumab in the red box on one side. That's hopefully going to come through. So there's, even now, there's more of a backbone now of first and second line. And certainly if you've used irinotecan or oxaliplatin first line, you can go on to the opposite one, second line. And again, we often substitute capecitabine for 5-FU. So you may be in your centres using oxaliplatin and capecitabine, for example. And certainly capecitabine on its own is a good drug. If you're of a poor performance status, I would certainly, if you've got somebody who's fit, want to give the more intensive regimens. So move on to the next slide. So what about after that? We've got 2 lines of treatment. We know they're good. There's a number of other things we can do now. As I said, when I started, there was 5-FU. Now we've got first and second line, and we've got so many other things. And there's probably drugs in the green boxes that you recognize. Regorafenib, trifluridine, and tipiracil is Lonsurf. We sometimes re-challenge. You might notice in your centres that somebody's had irinotecan at the start, then has oxaliplatin and has irinotecan again, and that can sometimes help. There's the combination of Lonsurf with bevacizumab, again, bringing that drug into it. And there's fruquintinib that's coming through as well. And in the pink boxes, there are newer combinations that are given in more on a trial basis at the moment. So the next slide. Now, this is really important. Doesn't look it, but it is. And essentially what it says is if you treat your patients properly, they will do better. And this was a looking at patient-reported outcomes. And essentially, if you act quickly on a patient's side effects, then they're much more likely to keep going with that chemotherapy and respond. So, for example, if a patient rings you and says they've got diarrhea, if you just ignore them, they're going to have more diarrhea and be admitted and never want chemotherapy again. But if you give them Imodium, you give them advice on diet, maybe add codeine, then you adjust the dose of chemotherapy, you'll find then that they tolerate it and can have more chemotherapy. And the same with nausea, same with fatigue. If you can control patient symptoms, even without these flash expensive drugs, you can make people live longer. So if you're going to give chemotherapy, essentially look after the patients afterwards. They will definitely do better. So the next slide. So I wanted to mention best supportive care. I suppose as an oncologist, I never want to do that because I always want to give a drug. There's a drug, let's give it. But sometimes it's best not to. It's very difficult emotionally not to give a drug. I'm sure if you've all probably got examples of I'm picking another age now, a 60-year-old that comes to you, they've had oxaliplatin, they've had irinotecan, they haven't responded to either. They're probably never going to respond to everything. And so it could be a reason to say, look, you've got a certain amount of time left. Let's just stop now and have a really good supportive care and try and help you to live the rest of your life as well as you can, rather than have chemotherapy. It's hard though, because most people want drugs, and I suppose at the end we often give drugs, but it's something to always think of, or at least use in parallel to these drugs. As I showed in that previous graph, if you give a patient good care, they're much, much more likely to do well. And so there's many reasons for best supportive care. and something to think of, but I accept it's hard to just do nothing really at times. So if we're going to do something, if we go to the next slide, so that's, as I say, that's about 5 months of survival. So the next slide, this is 2 big trials together, one with Lonsurf, one with regorafenib. And you can see in both of them, the median survival, when you've got somebody come to you for 3rd-line treatment, so they've had oxaliplatin, they've had irinotecan, they're now on 3rd-line treatment, their median survival by doing nothing is about 5 months. If you give these chemotherapies, it takes it to 6-7 months, something like that. So it's not a huge difference, but there's an advantage there. And I suppose it depends on the patient. Some patients may feel that that isn't worthwhile, but the vast majority think it is worthwhile and usually want one. Certainly Lonsurf, regorafenib is a slightly harder drug to cope with. If we go to the next slide, and the next one. Now this is the combination. It's called the Sunlight trial. And this is the combination of Lonsurf and Avastin versus just Lonsurf. So does Avastin, does that bevacizumab, does that make a difference? And go to the next slide. And what you can see there, it does. The 2 lines are far apart. I know I'm showing you a lot of survival curves, but ultimately that's what we want to show. We want to show that a patient's survival is better. There's no point in talking about their response rate or other things. You want to know if they live longer. And you can see here, if you give Avastin with Lonsurf, rather than having 5 months survival with doing nothing, or 7 with Lonsurf, you're now going up to about 11. So it's a big difference. And if you think of a patient now, we're in November. So if you just do best supportive care, you might get a patient just through Christmas and a bit more. If you give Lonsurf, you might make Easter. If you give Lonsurf and Avastin, you might make next summer. So if you think of it in that way, these drugs can be really helpful, and it's often well tolerated as well. And so the patient's quality of life doesn't drop too much. So the next slide. And this just shows some of the figures there. So the next slide. And the survival. There's another new drug, fruquintinib, and that was compared to placebo, because obviously at that time they didn't know if it helped. And so you had a big trial looking at fruquintinib or placebo. And if you go to the next slide, you can see another survival curve. But again, you see the split. You see patients do better with fruquintinib. And so I mentioned before, 5 months was best supportive care. They've got exactly that. They've got more than 7 months. But the big advantage of fruquintinib is that it is so well tolerated. All drugs have side effects. We've had a patient recently that had perforation through the tumor, which may be related to fruquintinib. But overall, fruquintinib is really well tolerated. And that's what you want. When a patient perhaps hasn't got much longer to live, the last thing you want to do is actually affect their quality of life. You want them to live a little bit longer with the best dignity, the best quality of life. So next slide. And re-challenge, again, this is another complicated slide, and I certainly wouldn't ever expect you to read it. But what it reminds me to say is that re-challenge is useful. There are a number of studies here that do say that if you've got a fit patient that's had oxaliplatin at the start and can still have it later lines of treatment, it can be reasonable to give it again because you can get a more of a response to it. And the next slide. And the next slide. Now, this is really interesting. I think the Welsh, if there's anybody from Wales here, they've caught on a lot quicker than the English and the Scottish. I understand that you can have blood tests in Wales, and often it's based on trials like this. Because, for example, I mentioned at the start that to benefit from cetuximab or panitumumab, you need to be wild-type RAS. And often what happens is a patient will have that drug and then become resistant. And you'll find if you look at a biopsy again, or much easier, look at a blood sample to look at your circulating tumor DNA, what you can see there is that they become mutants at that point, and that's why they're not responding. But then they can become wild type again a number of months later. Probably could be up to a year later that they can become wild type again. And so then you can give cetuximab or panitumumab again. And I think this is the way we're going, is that I hope in the coming years, we'll be able to take a blood test at the start, look at all the mutations. When they start to progress, we do another blood test, look at their mutations, and we try and direct the treatment depending on the mutations. And that's not something that's sort of pie in the sky years off. You can see a graph there with it. You can see in Wales now, I think they're doing that for some patients. It's happening. And I think in the next few years, blood tests, these liquid biopsies, will come in a lot more to look for these mutations. So the next slide. Now, immune therapy, you have to mention it. This is for immune therapy for the proficient mismatch repair. I'm going to mention it later on for that small group, the deficient mismatch repair. And essentially, these are two new immune therapies. So immune therapies are becoming better and they're becoming more combined. Rather than just having pembrolizumab, you've now got nivolumab and ipilimumab. So there's other combinations as well. And it does look interesting in patients with proficient mismatch repair. So it may be in the years to come, immune therapy will come in there. But at the moment, this is just in trials. And the next one, please. In this particular one, this immune therapy, though, as with all things, you start to look which patients benefit and which don't benefit. And you can see the top waterfall plots, that top slide there, the top graph. All the ones on the right, their tumours are growing, and they're all in red. And those ones there have active liver mets. Whereas the ones on the right of that box, the waterfall plot coming down all in blue, the tumours all getting smaller there, those are the ones with no liver mets. So what we're seeing already is that we're probably getting a subset of patients that don't have liver metastases that respond a lot better to immune therapy than the ones that do. Not exactly certain why, but that's what seems to be happening at the moment. So next slide. So I've come back to this. We've talked about the top two pink boxes, the FOLFIRIs, then the FOLFIRIs or FOLFOX, we swap them around. We've now got Lonsurf with Avastin. We've just shown that the survival is so much better. We've got fruquintinib as a fourth line because we know that one works and we know that people cope with it extremely well. There's also regorafenib there as well. So we've now pretty confidently can give 4 lines of treatment to patients. And it used to be that the performance status of patients used to deteriorate and very few people got 3rd or 4th line. Nowadays, actually the care is a lot better and probably you'd expect at least half the patients that you see to get 3rd line treatment. So at the Christie, for example, if we say we've got 300 patients having 1st line chemotherapy, we'd expect about 150 to go on to Lonsurf and Avastin and more. So it's so much better than it was, and that is why people are living longer. So the next slide. There's immune therapy coming in, and the next slide. So what about the newer, the genetic subsets? We keep measuring these things. I know a lot of you probably are sending off tissue. What's the HER2 status? What's the BRAF status? What's the RAS status? We talked about RAS. So there's lots of subsets now. And so this is the palette. I've got it as represented here. So if we go on the next slide, this is for BRAF. And again, I've got my colourful box picture at the top. You've got the receptor. And the receptor in this case is the growth factor receptor at the top. You've got the signal transduction pathway, and if you look down that in the actual main diagram, you've got RAF there. So we're talking about BRAF there, but you've got RAF just below the RAS one there, and then the nucleus at the bottom. And again, if you've got a BRAF mutated tumour, they don't do well, and that's the sad thing. They do really quite badly. So if we look at the next slide, BRAF, as I say, patients do badly, and it's about 10% of patients will have a BRAF mutation, and unfortunately, they won't do very well, or they wouldn't do very well. But the reason I'm bringing this up is that there's new treatments for it. So if you move to the next slide, there's things called BRAF inhibitors. As you can imagine, you've got a BRAF mutation, you want to inhibit it. Now, the thing is if you give a BRAF inhibitor to a patient with melanoma, you can see the top waterfall plot there. A lot of them respond. All the colours all dropping below that line. And so they're all dropping below the big, thick red line. And that means they're responding. So you give a BRAF inhibitor to a melanoma patient, they will do well. You give it to a colorectal patient and they won't. A BRAF inhibitor is useless on its own. There's no point. It won't help you at all. So if you move to the next slide, and this one, actually, I should have probably had this one just the slide before, but this shows you how bad BRAF patients do. You can see the blue line at the top is if you're all wild type. So if you send your genetics, you're wild type RAS, wild type BRAF, your survival will be about 3 years, is what I really said right at the start of my second slide. If you've got a mutation of the RAS gene, it's about 2 years. A mutation of the BRAF gene is a year. So imagine telling a patient that you've got a mutated BRAF. It's not good. And so the only reason to tell a patient or to check these things is there something we can do for it? And we know that a tablet BRAF inhibitor just won't help. So if we move to the next slide, there was a study looking at, well, look, let's give a bit more. Now, encorafenib is a BRAF inhibitor. And so in arm A, they had a BRAF inhibitor, they had cetuximab, an EGFR inhibitor, and they had this binimetinib, which was a what's called a MEK inhibitor. So they had 3 drugs. All of those drugs inhibited that pathway. So if you remember my diagram at the start, it inhibited the receptor at the top. It inhibited the signal transduction pathway. It tried to stop that horrible BRAF cell growing. Arm B was just 2 drugs that inhibited the receptor with cetuximab and the BRAF part of the signal transduction pathway with encorafenib. And then was the control arm with the drugs stated in C. So if we look to the next slide, you can see here arms A and B are overlapped in blue and red. They did so much better. So we just said it right at the start, encorafenib is actually of no use on its own. If you gave encorafenib, it would probably follow the black line at the bottom. But you give it with cetuximab, it helps. It really does help. There's a huge split. The patients with those drugs do so much better. So what we show now is that giving encorafenib and cetuximab, which we routinely use second line, so after the normal first line treatment, does help patients. So if you go on to the next slide, there was the next thing that came out is called the breakwater trial. And essentially, as with all drugs, you give them to patients when they're new. You give them to patients at the later setting, so in third line, something like that, to see that does it help in these really hard to treat patients that have already had chemotherapy. But as you get more evidence for them, you start to bring it up to the second line and first line. And the breakwater trial was a first line trial of all patients with a mutated BRAF. So they were going to do badly. And they gave encorafenib cetuximab, or they gave encorafenib cetuximab and Folfox, oxaliplatin 5-FU, or they didn't give the encorafenib, the control arm C again. So if you go to the next slide, and you can see there that graph at the top, another survival curve. And what you can see there, the standard of care, the ones without the BRAF inhibitor and cetuximab, the blue line did actually quite badly. And they've got a median survival there, about 15 months is what I said at the start. And as I said at the start, also, what is the point in measuring BRAF if you can't do anything about it? Here you can. You give encorafenib, cetuximab, and oxaliplatin 5-FU, and you're getting a median survival now of 30 months. So you're bringing those hard to treat patients, you're bringing right up to nearly the 3 years. They're doing so much better. And so that's what's just come out, the breakwater trial. We can't give it in that combination yet, and we might not in England certainly be able to give it for another year because it has to go through NICE. So it's looking good. I'd love it to give it to patients now, but we can't at the moment. At the moment, we have to give Folfox or Folfiri and then give encorafenib and cetuximab. So we have to do it in the second line. We can't give it in the first line. So if we go on to the next slide. There's HER2. If you'd have heard HER2 in breast cancer, again, my little diagram at the top, the receptor, signal transduction pathway, nucleus. So you've got all of the HER2 receptor, the HER receptors at the top, the signal transduction. You can see in the middle, RAS, RAF, MEK. You're getting to recognize these things now, the signal transduction pathway, and the nucleus at the bottom. So what about HER2? And if you go to the next slide, you can see here that about 5% of patients with colorectal cancer have amplification of HER2. So they're roughly, that makes them like a breast cancer cell that's going to respond to Herceptin. And these patients had a combination of two drugs, lapatinib and trastuzumab, which is Herceptin. And you can see with the waterfall plot on the left side, all those red lines are going downwards. So those patients are all responding. So patients with a HER2 tumor are all responding to this breast cancer type treatment because they're the 5% that are HER2 positive. So that's why we measure HER2 now regularly. And if you go to the next slide, we can see here, this is with another combination of pertuzumab, another HER2 inhibitor, and Herceptin again. And again, a lovely waterfall plot when lots of patients are responding to this combination. So the next slide. And it's like I said when I said earlier on that you're finding subsets like with immune therapy. It's only really those ones with the liver metastases that responded. Here we can see in the red boxes there, the ones with wild type RAS responded better, and the left-sided ones responded better as well. So you're always finding when you do these trials, you think, great, it works for everybody. But then you're finding some patients that it doesn't work that well for, but others it works really well for. So you're trying to select which group and you can target the right treatment at that right patient. So the next slide. And this here is a study called the Mountaineer trial, which is looking at taquitinib and Herceptin, another combination in patients with HER2 amplified tumors. And you can see there in that waterfall plot, that very colorful graph there, a lot of the lines are going down, which means a lot of patients are responding. And so there's a bigger trial with the next slide called the Mountaineer 3, which is looking at exactly that. And I've just said how great these treatments look, but you really have to compare it to the standard of care. So you've noticed a lot of the trials earlier on with BRAF and other things is that you've got to have your best treatment and compare it to standard of care. And the hope is that the new treatment works. And you might think, I've shown you everything that works so far. That's not always the case. I'm obviously not showing you negative trials, but in my time, I've seen a number of trials we've done that haven't worked out as well. So we have high hopes for this one because it seems so good in the smaller trial. So the next study, next slide. So immune therapy, if we're moving on to that now. And immune therapy is always seems complicated, and you probably know it's used in virtually every cancer. And essentially, if you look there in this diagram, there's a T cell, so a white cell, and there's a green cell, what's called the antigen presenting cell, which could be a cancer cell. And so what's happened is the T cell and the cancer cell are joined tightly together, and the T cell doesn't work, and the cancer has evaded the immune system. So the cancer carries on growing quite nicely, and the immune system does nothing. And they're bound together. And if you can see in the center, there's things like PD1 and CTLA4. These are all the complexes that bind them together. And if you people that have used immune therapy, you might have heard of a PD1 inhibitor or a PD-L1 inhibitor or ipilimumab, which is a CTLA4 inhibitor. So you can imagine what I'm going to say here now is that you've got them bound together by these receptors. What happens if you break them apart and split them up? So if you go to the next slide, actually go to the next one after that. I'm sorry. If you split them up, if you go back one, sorry. If you split them up, what happens is this T cell comes apart from the cancer cell, and then the T cell can really work and kill off the cancer cell. So by giving these inhibitors to break them apart, things like pembrolizumab or nivolumab or ipilimumab, you're breaking the two cells apart, and so the immune system works again, and so the cancer isn't evading the immune system. And that's why it works in every cancer really, because all of the cancers got the very similar thing. T cells are not working because they're bound to the cancer cell. Splitting them up, they start to work. In colorectal cancer, as always, I've said earlier on, sometimes there's subsets that work really well. And what we've got in colorectal cancer is the deficient mismatch repair ones. And so you probably remember in your MDTs, people keep saying, well, what's the mismatch repair status? If you're proficient, you will not respond to immune therapy, only in trials. I mentioned that trial earlier on, but that's in trials. That's new stuff that isn't absolutely here yet. But the deficient mismatch repair ones can respond really well to immune therapy. And that's why we want to know. That's why all the oncologists are always asking, what's the mismatch repair status? So if we move to the next slide. And you can see here, this was a study in the second line or third line. So it's patients that have already had chemotherapy. They first of all gave nivolumab to see, look, how do people cope with it? Because it's a new drug. Are they going to cope well with it? And so that was to break the T cell and the cancer cell apart so that the immune system works again. And then when they worked out that the nivolumab worked, and the nivolumab was tolerated, they added nivolumab, ipilimumab to it. So it's one drug, then two. So if you go to the next slide, and you can see here, these are for patients that are very heavily treated and now actually doing quite well. And if you click the clicker again, I think another line is going to appear. Yeah, this is what happens at these patients. If you gave best supportive care then to these deficient mismatch repair patients, they would do dreadfully and they would die very quickly at that stage. Their median survival was about 5 months and they would die with that, and they would follow the MOVE curve. If you click the next line, that's best supportive care. The next one, and click again. That one there is Lonsurf. So it's better than best supportive care, but it's still down there. If you click again and again, you get Lonsurf and Avastin. So again, all of these drugs are helping there, but there's nowhere near as good as with the immune therapy. But as I said, this is only in the deficient mismatch repair, and that represents about 5% of patients with advanced colorectal cancer. So sadly, the other 95% will not benefit into immune therapy, but only in trials. But in that group, they can do really well. So the next slide. So we found out that it works second and third line. What about first line? Let's give pembrolizumab right up front to patients. And they compared it to the best chemotherapy you could choose yourself, anyone. Let's hope it's good as the standard chemotherapy, but let's randomize it to pembrolizumab. So next slide, please. And you can see here, the blue line is the pembrolizumab line. They do better. And so there's no doubt giving pembrolizumab up front is good. Giving nivolumab and ipilimumab second line is good. Okay, they both help in that 5% of cancers. So if you go to the next slide, there was a study looking at first line ipilimumab and nivolumab. I've said it's really good second line, but what about first line? And so the next slide. And that was the study here. We looked at nivolumab, so one drug. So we cut one complex that was binding the tumor cell and the T cell apart. Then nivolumab and ipilimumab, so that gets rid of two of them. Or we give standard of care. So what's the best out of that lot? And so the next slide. And you can see here, this is looking at the two immune therapies, nivolumab and ipilimumab, compared to chemotherapy. And what a difference there is. If for example, it was one of your family and you had deficient mismatch repair, you'd never really want chemotherapy in this situation. You'd really want to give the immune therapy because they do so much better. But is two drugs better than one? Is nivolumab, ipilimumab, is that better than just nivolumab, or is it worth giving two? It's twice the cost probably. So let's go to the next one. And you can see here it is. Nivolumab and ipilimumab is better than just nivolumab. Okay, so two immune therapies are better than one. So the next slide. So here it shows that, I suppose with everything, if you add another drug on, you're going to get more toxicity. And there is, looking at it, more toxicity there if you have two immune therapies. But if you go to the next slide, you can see this is the quality of life. And you can see here, the brownie one line is the one with nivolumab and ipilimumab, and the green one is just nivolumab. And you can see here that the quality of life is very similar with both drugs. So even though you're giving 2 drugs compared to 1, the quality of life is still very good. And so there are certain instances you might want to just give perhaps just pembrolizumab, and there's other instances where you might want to give nivolumab and ipilimumab, but I won't go through that now, but they're both really good treatments. So the next slide. And you can see here NICE. I mentioned bevacizumab is going through NICE tomorrow. You have here, we're allowed to give pembrolizumab or nivolumab, ipilimumab first line. And the second line, you can give the same things. You can't go from one to the other. There's no point because they all work very similarly. So you can't go from pembrolizumab to nivolumab, ipilimumab. Hopefully you'll pick up a mismatch repair at the start, and you put them straight on one of those drugs, the combinations at the top. So next slide. They do have toxicities, and you can see this slide. They seem to call itises. Like you can get thyroiditis, you measure the thyroid function. You can get pneumonitis, you can get myocarditis, you get colitis. You get all of these things because essentially what's happening is you're splitting up the T cell from the cancer cell, and the T cell is attacking the cancer cell. But the T cell is also attacking your body. It's attacking your lungs. It's attacking your liver. It's attacking your muscles. It can attack your brain. So yeah, you can have problems with it. It's not as if everybody doesn't have problems with immune therapy. But you can see right at the top there, I've said here under the immune-related toxicities, about 50% get something of a side effect. So half don't, but half do. Probably about 10 to 20% is severe. We notice it. We notice it on the blood test, or the patient get quite an itchy rash, or their thyroid won't function properly. But probably only 2 or 3 in every 100 we have to stop treatment. So if you compare that to something like, as I said earlier on, Folfoxiri, it can be a dream, this one, for patients compared to some of the combinations chemotherapies. So it's got its toxicities, absolutely, but it's often very well tolerated, and even the very elderly can cope very well with immune therapy. So the next slide. This shows, again, if you get a side effect from immune therapy, you're going to do better. It's the same as I said earlier on with cetuximab. If you get a rash with cetuximab, you're going to do better. It often, with 5-FU, for example, if you give somebody capecitabine, which is like 5-FU, if you give them that and they get no side effects, they're less likely to respond. So often with chemotherapy, it's nice to see some side effects because it's a sign the drug's being activated and then can actually work and attack the tumor. And you can see here in the bottom right-hand graph, you can see here, if you have no adverse event, you follow a blue line going downwards. If you get a adverse event, it's better. Patients live longer. So with immune therapy, if you get somebody has an itchy rash and a slight effect on their thyroid, often I feel great. That's good. They're getting something here. The combinations being the immune therapy is working, and the immune therapy is attacking the cancer at the same time as attacking your skin, for example. So the next slide. It's odd with immune therapy. You'll find this word pseudoprogression going around, and you might find in clinics when you're in with consultants there, or registrars, whoever you're with, or the nurse clinicians, and you can see there that sometimes the tumors can get bigger with immune therapy, and sometimes what happens is they've just got loads and loads of white cells just go into the tumor and make the tumor bigger. So in fact, it's not the tumor getting bigger, it's the immune system that's making the tumor get bigger. And so all 3 examples here, if you look at all of them, A, B, and C, the tumor looks bigger. You can look and see at the bottom. They now look obstructed over on the very bottom graph there, slide there. But all of them responded. No tumor was found. So in fact, patients can respond really, really well to treatment, but sometimes you can't always tell it on the scans, and you have to take courage and think, well, they've probably got a pseudoprogression, let's carry on a bit. And so there's often these discussions in MDTs. So the next slide. I've got a final few slides now. There's a new things coming out. We've talked about RAS wild type can have cetuximab or panitumumab, but the mutants can't. And the mutants represent more than half the patients. So what about those poor patients with a mutated RAS? There's now RAS inhibitors. the same as all the other things. A BRAF inhibitor, there's now a RAS inhibitor. And so if you go to the next slide, and you can see here, if you look at, you can see the picture of a colon there, and next to it shows there's all different types of RAS mutations. And the two drugs that are coming out at the moment are G12C inhibitors and G12D inhibitors. And so if you remember, I showed you a slide earlier on with 3 lines with RAS wild type doing well, RAS mutant doing not so well, and BRAF mutant doing really badly. So RAS mutants don't do so well, and there's now inhibitors of them. So if you go to the next slide, and you can see here, this is a combination of a G12C RAS inhibitor, and it should say cetuximab at the top there. I've missed out a T, but you can see what a wonderful plot there. All of the lines are dropping down, so all the tumours are responding. So what you're finding there is you get lots of patients that normally do very badly can now have these tablet RAS inhibitors in trials at the moment, but they can respond really well. So the next slide. And there's G12D inhibitors as well. I won't go through this in detail, but there's more and more. There's even pan-RAS inhibitors now, which means that they inhibit all of the different mutations. So it's an exciting time for RAS as well. So the next slide. And there's newer ones coming through. As I said, there's pan-RAS inhibitors as well. This is an old slide from 2023. I'm sure it's probably 2 or 3 slides now you can put from different drugs that are coming out. There's so many that are appearing now, all in trials. So next slide. So we've got this pink backbone, if you remember. We had nothing 20 years ago. We had 5-FU. We then had the oxaliplatins, the irinotekins, the top pink boxes. We've then got Lonsurf and Avastin. We've got fruquintinib. All the green boxes have appeared. You've got the pembrolizumab, the nivolumabs. We've got the encorafenib cetuximab. We've got bevacizumab hoping to come through. HER2 inhibitors hopefully will come through. It's an exciting time. There's so much more. And the next slide. And you've got the RAS inhibitors I mentioned there. And next one. And immunotherapy. So there's so many things that are coming through. So what I hope I've done here, I'm going to open up to questions in a second, but years ago we had 5-FU, 25 years ago. Now we have so many drugs. They're all becoming better tolerated. They're all becoming more targeted. They're all making patients live a lot longer. So it is a good time for patients. It's a good time for us as clinicians, whether you're doctors, nurses, because at least you can give patients hope there. There are new trials that are coming through, which is great as well, to get patients into clinical trials with even newer drugs. So it's an exciting time, and hopefully you won't remember everything from this talk, but at least if you remember, loads of drugs now, survivals are much better, targeted drugs are good, and patients are going to do well from this. So thank you very much.
Thank you so much, Mark. That was a fascinating talk, and you, as you always do, you managed to cover this really complex topic and make it really accessible. So thank you so much. We've got a few questions come in. I've got one that someone sent in before, just to say, do you find that patients are becoming far more expert about their own care and discussing their RAS status and MSI and bringing that to you?
I think there's a whole spectrum of patients, but there's no doubt about it that there's some that are extremely well read and want to know everything about their different genetic status. They want even more genetics. They want all the trials. There is that. And there's other people that really don't want any of that. They can be equal intelligence. It doesn't always follow with that, because you might find somebody that just wants me to do it all and rely on me, and let's not ask all these questions, really, because sometimes the answers are not good. If they ask, well, what mutations have I got? Well, how will I do with that? It's hard to answer sometimes. At least you can say, well, look, there's a really good drug here you can give for somebody for it. But yeah, people are much more well read, so it means that we have to be well read as well to go and answer all the questions for the patients as well.
Yeah, certainly. I've just seen a comment come in actually from Claire Taylor saying it's really exciting to hear about the personalisation that we can now offer. And so much of that is about how we counsel our patients as well, isn't it? And how we talk to them about the effects of the treatment and the impact of the treatment.
Yeah, yeah, definitely, definitely. It's I think it's we I suppose I always say we're there for guidance. We tell them the best available treatments, and whether that's with us or sometimes I have to refer to other units to for other trials. So we've all got to think about it's. I don't own the patients. It's actually what's best for them, whether under me, under a surgeon, under a liver surgeon, under a radiotherapist, or under an early phase team. Yeah, so exciting times, lots of questions, I think, from patients and lots of things we can do.
Yeah, they really are, and so different to how things used to be.
Mm.
Um, we have some other questions. So this one came in right at the beginning. I think was reference really to cetuximab. Could treating the rash with antibiotics potentially reduce the effectivity of the treatment?
No, it won't do. No, I think it's so important to treat them with antibiotics and the various creams because I'm sure whoever asked that question, if they've seen somebody with an awful rash, it can be horrendous. And the patient, if you don't treat it, will stop earlier and they will die quicker because they won't have any treatment. So you've got to treat the rash. Antibiotics are really good to get rid of the rash. By giving the cream, the antibiotics will not affect the effect of the drug on the tumor.
Yeah, okay. Someone else has put a question about saying it's interesting to say people do better on chemotherapy if they have a reaction to it. But if the reaction is that strong, do we not have to stop the treatment and therefore delay and
I,
potentially?
I do agree. I love a little bit of a reaction, but you don't want them to be admitted with horrible diarrhea, horrible nausea, and can't have the treatment. I absolutely agree. But there's no doubt if you look at cetuximab or panitumumab, the more rash, the better they do. You look at 5-FU, the more side effects, the more likely they are to respond. Immune therapy, exactly the same. So it's coming up with multiple drugs. You've got to have some side effects, but a patient's going through with absolutely no side effects, you can worry, are they going to respond?
Yeah.
It doesn't mean they're not, because I've seen loads of patients that have had no side effects and have had a marvelous response. But yeah, you want some side effects, but not horrendous side effects that you have to stop it. I agree.
Yeah, and it's interesting, isn't it? Because I always used to be really relieved when they said they'd sailed through, and I know that sometimes it isn't bad as you say, but now I feel a little bit. Oh, did you?
Mm,
Because you're kind of hoping to see some response, reaction, aren't you?
that's it, exactly. No, you are definitely.
There's another question coming in the Q&A here. It's just, do you have any advice for patients seeking a second opinion when they've been told there is no further treatment by their oncologist?
Yeah, I do let them. I mean, I get roughly about 100 second opinions a year because not because of me, because we're a big centre, and so they often refer to the Marsden, the Christie, or places like that. So we get a lot of second opinions, but I also refer patients for second opinions as well. And I think sometimes it's very helpful, and I try to work with the patient to do that. So I often offer it, and if a patient wants a second opinion, I will write to an oncologist that I have a lot of respect for that I think is going to give a good opinion. I think if you try not to work with the patient, they will sneak off getting a second opinion somewhere else. And often they can get it from somebody who really probably isn't going to provide them with the best opinion. And certainly when there's money involved, sometimes, and I'm not saying oncologists can be unscrupulous, but there's no doubt, I'm sure anybody here watching probably knows that this money can actually get people to do different things really that they normally wouldn't do. So I would work with the patient. I would feel that a lot of the time if I offer a second opinion, I think the very fact I've offered it, actually they don't want it now, they just wanted to know if I do it.
Yeah,
and
yeah,
and so I do that, and yeah, no, I refer for second opinions, and I find it very helpful to get another oncologist to say, yeah, you're doing the right thing, or to come up and say, I had one that went to Harpreet Wasan recently, went down to London. He came up with a good idea, but he actually was very sensible because it wasn't funded. And so he actually didn't come back and say, I'm the great doctor, I can do this. He came back and said, quite rightly, there is this, but it's not funded at the moment. The benefits are very small, but at least gave a good opinion. And I think the patient found that helpful, and I found it helpful. And we're still treating the patient up in Manchester. So it's second opinions can be great by the right
yeah.
person.
And actually now where treatment has become, often a marathon and not a sprint. We've got all
Yeah,
these options. It's a
yeah.
long-term relationship of trust and working together, isn't it? I think.
It is, and that's the thing is, I think if you ever lose that trust, and sometimes it's sadly, sometimes if somebody goes in and the patient doesn't think they know the story or they upset them somehow,
Mm,
that can ruin sometimes 2 or 3 years of work by a lot of people, the nurses, the doctors, the secretarial staff, all admin staff, because everybody works together to try and give, I hate the word journey. Journey seems nice, but make that journey nice,
mm,
really. And so
mm.
it is important. It's a long haul, really. You want to make sure you just keep going at it right from start, and really to best supportive care and that. Yeah.
Yeah, certainly. Sorry, I'm conscious of your time. We've got a couple more questions.
I've no rush. No.
Are you
Mm,
all right?
mm.
Someone has just asked, hang on, it's gone now because they didn't put it in the Q&A. Maybe it's gone to the Q&A. Yeah, here it is. Is putting the patient on steroids treatment to be addressed to address their current symptoms, will this affect the immunotherapy?
Yeah, I think that's a very good question, and all these questions are good. But that one is a good one as well. Essentially, I suppose immune therapy makes your immune system attack the cancer. Steroids stop that happening. So why would you put them on steroids and immune therapy? It seems a very low dose of steroids, probably up to about um, a milligram of dexamethasone or 10 milligrams of prednisolone is probably all right. That's not going to do a great deal, and that might help patients. But if you start putting high dose steroids for patients with immune therapy, only immune therapy, not the other drugs, then you might be counteracting the effect of the immune therapy. But again, there's a balance there. Sometimes, if a patient has just a tremendous immunotherapy response that's attacking the tumor and attacking your body as well, you have to give high dose steroids to stop that happening. So you give the steroid, you don't give the steroids if you can, if the immunotherapy is working. But if the immunotherapy is working too much and you're attacking your body, you have to give steroids then anyway to stop that attack on the body.
Thank you. That is a really helpful answer. Thank you. Um, there's another one here. Does the treatment being adjuvant or neoadjuvant change the type of treatment, try and change the type given?
Sometimes it does. Adjuvant is getting more simple nowadays. It's either going to be capecitabine or capecitabine and oxaliplatin. Those are the only two that have really been proven. And if anybody who's listening has been doing the Scott trial, that's where that came for,
Mm,
looking at 3 versus 6 months. So
yeah.
there's only two drugs. Whereas neoadjuvant, you might give folfoxiri, you might add irinotecan, or you might add cetuximab or panitumumab in the right patient. So it's a slight difference there. And I suppose often the question is asked is, if you give if you give 3 months of neoadjuvant, do you then have to give 3 months of adjuvant? That's uncertain, really. And I think you'd find lots of clinicians give different opinions. And often it's very much depends on the patient and the patient's pathology. So there is slight differences there between the two of them,
Mm,
neoadjuvant and adjuvant.
thank you. And another question, what are your thoughts on the Artemis trial?
Artemis trial. Well,
Yeah.
I suppose I run that one as myself and Simon Gollings are the chief investigators for it. So I'd be a bit odd to say I didn't like it. I think it's great. But with all things, I think other people think it's good as well, because we want 140 patients and we've just passed the 100 mark. So we've only got 40 patients left. So we're keeping to recruitment. So at the moment, I think it's going very well. I think whether it works or not, because the Artemis trial, for people that don't know, is with a new immune therapy and chemoradiotherapy.
Mm,
If it doesn't work, it means that everybody is now using the same new radiotherapy techniques to plan patients. So I think with all trials, positive or negative, sometimes if you can get people doing the most up-to-date treatment, is actually really good. So I think it'll be a success in that way. Will the immune therapy arm be better? I don't know. We just don't know yet, but it's going well.
yeah, and it's certainly a very worthwhile, isn't it? It's an interesting. Okay, final question is just about use of proms. Do you use them routinely in your own
Um,
practice?
it's starting to come in at the Christie, and so yes, we are occasionally looking at our electronic notes, and we're seeing that, and I think it's very good. And it really, when you saw one of the earlier slides I had, when I said that keeping good care of a patient is really good, because it means that you're going to control their symptoms, give them better quality of life, and make them live longer. Um, yeah, I think proms are really good, and I think sometimes us clinicians and maybe nurses as well, we go in, we're rushed, we ask them, yeah, you're doing all right, yeah, a bit of fatigue, yeah. But actually, if you get down what the patient writes down, actually sometimes very different. They have a lot more things. So I think relying on patients for their patient reported outcome measures is really good. So I'm a big fan of those, but I think they're just about coming through, I think, outside clinical trials, I think.
Yeah, I would agree, and I think I'm trying to use them in an effects of cancer treatment clinic that we're running that's new because it evidences the impact as well. So as well as seeing the effect of treatment and helping us to manage those side effects earlier, further
Yeah,
down the line, I think it can really help with evidencing services and how beneficial they are to, improving quality of life and getting people back into the workplace and the economy and all of those things that
yeah,
we need to evidence to
yeah.
have services. Um, there is one final question. Are you willing to take it? Sorry, I know you probably do need to go.
What's
Um,
that? No, no, no. Cool. Oh no, sorry. I wonder what you're going to ask me where you said it. No, no. I've got.
no,
I'm
it's
happy
fine.
with the
It's
question.
do we have a timeline on how long we give the immunotherapy drugs? Also, how often we scan the patients in the interim?
I think with the immune therapy at the moment, it seems to be 2 years, and it still is 2 years. And so once we start it, and that's why it's quite expensive because I think it's tens of thousands each year that you pay for it, but it's 2 years. But there are studies looking at giving it for perhaps a year, less time as well. So at the moment, if you've got somebody who you're starting on pembrolizumab or nivolumab, ipilimumab, you're starting on a 2-year plan of giving it. And in terms of scans, we normally scan every 3 months, the same as we do with other chemotherapies, because we want to find out early if they're responding and early if they're not responding as well.
I thought it was really interesting what you said about, you have to be quite brave as well, because sometimes you see what you think is possibly progression or non-response, and that's not the case. So it really emphasizes the importance of a good MDT, doesn't it? All of that.
It does. I mean, remember a classic one actually. I saw with all the comments coming up there. Vicky Kenyon, one of the nurses at Salford Royal at Hope. I've been there, going there for years, and working with all of the nurses there. And we had one patient that had. It started off with probably like a grape of tumor, and then everything responded, and that grape got to a walnut, and eventually got to a plum, and it got bigger and bigger, and eventually it was removed, and it just turned out to be lymphatic tissue. It didn't turn out to be cancer at all. It just that the body was just fighting that cancer so much, and just there's just a big conglomerate of lymphocytes there. So yeah, it is, and we eventually removed it. Yeah, it is hard. It is hard, and that's the advantage of MDTs because you get
Yeah.
multiple clinicians, you get the radiologist, you get everybody chipping in. And sometimes, if the patient is well and there are only minor changes, there's no rush. Just do another scan, see how it's getting on. Don't rush in to do something rash. In these cases, sometimes you do have time to sit and think.
Yeah. Yeah, it's also important. Thank you so much, Mark. That was
Okay,
fantastic.
great.
Thank you
Well,
for your
thanks everybody
time.
for joining in, and yeah, I'll speak to you all again at some point. Okay, bye.
Lovely. Thank you. Thank you, everybody.